everybody, and welcome. Thank you for coming today. My name is Caity Massoud. I'm the host of Flute Unscripted's podcast called Flute Unscripted. So shameless plug, you can check that out on your phones later. And I actually have an episode with Mortimore here if you're interested in downloading that after the panel. We're here today to talk about focal dystonia, and this panel is the culmination of a lot of hard work of all the people that are up here. I have Dr. Frucht, and he is specialized in botulinum toxins, and with his work has improved the lives of musicians with focal dystonia. Mortimore is the principal piccoloist of the Metropolitan Opera Orchestra. We have Phinney, percussionist and member of Ethos Percussion Group. And last but not least, Victor Wooten, who graciously stepped in here last minute. If you're not familiar, he's a Grammy Award-winning bassist. He's a member of Bella Fleck and the Flecktones. So thank you all for coming here today, and a round of applause to you guys. So, as I was mentioning before, my podcast episode with Stephanie, she bravely and courageously wanted to do that episode with me and introduced herself to me to kind of make it a little bit more known about the symptoms, the treatments, and her journey with focal dystonia. It's something that's not really talked much about in the community of musicians. And in keeping in line with that, we wanted to have this discussion today to openly discuss, again, treatments, what symptoms look like for all these different musicians, a little background about dystonia, and of course at the end we'll have plenty of time for questions, so if you have anything that you're dying to ask anybody, there will be time for that. So we're going to get started. I thought Dr. Frucht could maybe explain for us just a little background about dystonia, what it is in layman's terms for everybody.
Sure, well thank you for having me. Sure. Everybody hear me?
Yeah.
So, delighted to be here. This is a unique sort of gathering because you don't have, to my knowledge, any prior examples of working musicians talking about their experience with focal dystonia, with the exception of Leon Fleischer. But focal dystonia is a neurologic disorder, a movement disorder. Dystonia is a peculiar movement disorder in which a part of the body is involved with involuntary movements that tend to produce sustained or twisting postures. By focal, we mean one part of the body, typically the hand. And it's task specific, meaning it occurs just during the performance of a specific task, such as writing or sewing or using an instrument, or in the case of musicians, playing an instrument. This is an organic disorder. This is a condition that arises in the brain, usually begins around age 30 or 40. The cause has been hotly debated. We don't fully know what the cause of this condition is. The treatments have improved dramatically from the time where this was originally thought to be a psychiatric condition. That's of course no longer believed. That really in the last 20, 25 years has evolved. The treatment has evolved substantially for many patients. So that we'll go over a little more of some of the examples. I have a few brief slides and videos to show, but that's
Yeah. And I was hoping maybe you could hear from all of you, what were your symptoms and what alerted you to know that you had something that maybe you should go seek professional help for?
Well, for me, I started noticing something maybe about 3 years ago when I just started noticing that it was more difficult for me to play with my B flat thumb key on than it was to play with the regular thumb, which makes no sense. But I thought I had stumbled upon some brilliant thing oh, we're all overusing the B flat thumb key, and so I started playing everything with regular B flat, and then I started noticing that my lips started shaking. That was the next thing. And then I had to prepare, I was playing Appalachian Spring in the summer. I was very excited about it because, it was the one flute version, and I'd only ever played it one time in my life, and I had just said to my husband, I'll probably never get to play this piece again. We'd heard it on the radio. And lo and behold, I get the opportunity. So I was extremely motivated to be like perfect on this piece. And I practiced, and there was just one passage that should be easy for me. It was just a simple scale. It should be easy, and it just was giving me like so much trouble. And I practiced it, and then I played the performance, and that part, it went okay in that part, but I couldn't get it in the practice room. It's just when I got into the performance, it went fine, but it was just so much time practicing. And then I agreed to do this wedding gig out there. So the bride happened to be from the family of quants. So she wanted a quants concerto at her wedding. And she did not choose the G major. She chose some other concerto, which nobody's ever heard of. And she gave it to me, and I said, no, I can't play that. So it was like in 2 days. Somebody else had backed out. So I said, well, I'll play the G. And I hadn't worked on that since college. So in 2 days, I had to play the concerto, and I had to play it with an amateur string trio. And so I was very tense, and we had to rehearse over and over. And the first time we could do it was that day. And then the bride was late, so we had to play it many times. And that was when everything started to go. So, but in hindsight, I do think that the symptoms started back in 2009 when I was taking the principal flute audition. And I just never had a name for what happened to me, because what happened was everything was going fine, and I was practicing Rosencavalier, and all of a sudden I couldn't play one of the excerpts, just one measure. And again, I practiced. I tried. I went to play for Keith. I played for friends. I like asked everybody, and I couldn't get it. And I just never played that again. And then it went, it was fine. It was fine until like 3 years ago. So, yeah, that's my experience. Eric?
Okay. Yeah. Okay. Yeah, a lot of similarities. I mean, I'm a classical percussionist, but one of my specialties are the drums on the floor called the tabla drums. And they're a classical Indian instrument, and it takes many years, and it's a really intense instrument to study. And I was at a tabla seminar in Vancouver, and I had been practicing a lot that whole calendar year. And when I got to the seminar, I had made a point that I was going to really push it. I was going to break through to the next level, as they say. And over the course of a week, I noticed my right index finger starting to curl towards the center of my hand a little bit. And I didn't think anything of it, and I kept going, which is a really terrible thing to do in hindsight. But, and my condition started to really went off the cliff like one day. And it was just like, I couldn't play anymore. And it was completely curled into the middle of my palm. I could reset it, and within a second or two, it would go right back to that position. And I really only did that when my hand was on the drum. When I was curled, I had drumsticks in my hands, everything was okay. But my fingers didn't work correctly when I needed them to. And I let the condition go for about a year, maybe a year and a half, because I just thought it was fatigue or tendonitis or something, until somebody asked me to go see somebody. And that's where we'll talk about that.
It sounds like we all kind of have similar stories where it just kind of surprised us and came in. I play bass guitar mostly, and some double bass, acoustic bass, and mostly in the jazz world. I get called to play mostly jazz. But I can remember, and talking to bandmates probably 15 to 20 years ago, my friends are telling me that they can remember me saying, man, my fingers just feel sluggish. Like they're just not moving the way they should. And I do kind of a different type of thumb technique on the bass, and I'm thinking, maybe I've just been working on the thumb technique too much. I need to start working on my fingers again. So I really start practicing, but it's not getting better, and in most cases it's getting worse. The sluggishness, and I didn't know what it was until maybe a year and a half ago. As it's getting worse and worse, but let me say this, I never stopped playing. I found ways of playing around it, playing differently, because I had concerts, I had tours, I had to play. And I didn't really think of it much as a problem. It's just I need to play differently now. So I found some ways of getting around it. And maybe a year and a half, close to 2 years ago, I was talking to someone at a dinner about it. And someone on my other side said, "Sounds like you have dystonia." I said, "What is that?" And he started explaining it, and it sounded right. So that night after dinner, I went online, and I found these things on post online that described me to a T. You know, mostly the ring finger, a guitar player, whatever. For me, it is both hands. But since I use more fingers on my fretting hand, I can tell more, but I can tell it's in my picking hand also. But I will say this, as soon as there was a name for it, it got worse. I mean, for real. So that, for me, that was a good sign. Because for me, it was a good sign. Because it let me know that my mind is playing into it. And I feel that I have a strong mind, that I can use my mind to, the way I did before I knew there was a name. I just played around it. But now it's really been tough knowing that I have something.
And while you were playing around it and kind of making it work, were you ever afraid of people finding out? Or
No, that's never been my case of people finding out. And I'm fortunate enough that my instrument is the bass guitar. It's designed to be simple. It's the whole reason for the bass is to support other people. And I could always do that. I'm known for a lot more than that. And that was a little freaky for me when some of these things I couldn't do as well, and people are expecting me to do them at these shows. But as far as just playing bass, whole notes, and supporting people, I could still do that. But like you were saying, Stephanie, some of the simple things, a scale, starts to become totally difficult. And sometimes some of the more complicated things I could still do. But the simple scales, the simple parts started getting harder. So, but it forced me to be more simple and think about other things rather than technique, and just being musical on a whole and getting the job done when the technical part is not happening. It's been a challenge.
And have you sought natural remedies for treatment as well?
Well, treatment for me has just begun. I mean, I'm just getting into it. It's been a long road of research for me before I jumped into anything. So I've been reading about different treatments, and I'm just amazed to be on a panel with these people because I've read about them. You know, I read about the Botox study, and just like yesterday, I called this girl who told me about your article. I said, "Guess what? I'm going to be speaking with this guy." You know, for me, these are like heroes to me because I'm finally learning about that there are treatments. You know, some people say that can't be treated, others people say they can. So I'm open to everything. To me, the fact that dystonia is like magic that we don't know. So, which for me means I don't know what the treatment is either. So to exclude anyone could be a mistake. Even if somebody has, for me, if one treatment's 80% wrong, but 20% right, I want to know about it. So for me, I'm being open to everything.
I think this would be a nice segue for Dr. Frucht to maybe share with us a little bit more about the treatments that are out there and
Sure.
some options that are available.
Would you like me to show
Yeah,
some
the
of
power-
those?
yeah,
Yeah,
give the
let's see if
PowerPoint.
it actually.
Is it easier to hold
What's
the
that?
mic or?
Sure. So what you've heard is, like, I wouldn't say textbook, but it's as good a demonstration of what people complain about and what people experience as you're going to hear of the experience of patients.
It's hard to hear.
Hopefully.
Let's test it.
Can you hear me now?
Okay.
Yeah.
Better.
Seems to be going in and out. Yeah, it does.
It's Botox.
I don't know where.
We need to do what we did before. Put it back here.
There we go.
There we go.
Okay.
That's weird.
1 hour again.
Oh.
It's flickering.
Yeah, something is
Is it,
in and out.
okay.
Oh, it keeps going in and out.
Hold on.
If there's anything I've learned is that you can guarantee that technology will fail when you need it.
It's not on your
Anybody
computer,
call?
It goes into the phone. Is there a tech person? Does anybody know if there's a tech person that could be acquired?
There's one downstairs.
Because
I
maybe.
was just trying to reach them. Does anyone have Deirdre's?
I can text
text
Deirdre.
her.
Anybody here, no tech? Because we could, if we could get somebody to deal with this other than us, then we could continue and.
What?
Turn off the
Yeah.
projector. And leave the computer on, and then put the projector back on. It should be able to find. Oh, projector from there.
Yeah.
The projector has to go off. And then go on while the computer.
Well, last time I just plugged it in.
It's not what's happening is it's not going on. This looks like it turns it off right. I don't think it's not right. So I don't think that's all.
We're gonna try
Turn
that.
it off and turn it on again.
Pointing it out. There we go.
Give it about 30 seconds.
Okay. I'm good at following instructions.
While we're waiting, I thought I had something to say, like regarding what you were saying about we were talking about things being simple versus like harder things maybe
Yeah.
weren't as difficult. For me, that has been the case too, and just like slow is easier than middle speed, and fast is medium speed is the worst because it requires moving with great control, which requires a lot of brain power. Moving quickly, I recently learned that like the left side of the brain is responsible for not only the right side, but also for detail work. And the right side is responsible for the left, but also global motion. And it's more about like big picture and flow. And I feel like we get kind of dystonic patients, we get stuck in the right brain. And so we're like very like, have to think about everything. And once you can get your brain to go to the other side, then you can get rid of a lot of the symptoms.
Is that dependent on which hand you have the dystonia in?
That's a good question because like, I know some people think that like, I have it in my left hand. Most flute players have it in their left hand, but I do have a friend who has it in her right hand, and she is left-handed, and I'm right-handed. So it's a good thing, but I think it's harder to recover from if your dystonia is in your dominant hand.
Yeah.
Because a lot of the things that I do for practicing have to do with going off of my dominant hand, my non-dystonic dominant hand. So I check how things feel in that hand. How does basic movement feel in that hand? And then I can try to mirror that with my other hand. So,
Do you notice it in other activities besides playing?
I don't. I occasionally feel like my hand is like, I would sometimes be in a yoga class and I'd just be like doing corpse pose and I would feel like this hand was a little more curled than the other. But I don't have any problems with motor activities in anything else. But I know Victor has a different experience, right? You have?
Yeah, for me, I feel the symptoms mostly when I'm playing. But sometimes being on a computer, when my left hand reaches to touch the computer, these 3 fingers, I'll feel them curl. And so I'm like pointing. I got one good finger, you know. So, but if I relax it and let it do it, it'll do it. But the natural thing when I bring my hand up to the computer, you know, it'll do it.
This just needs another minute to reset.
Okay.
Right? Yeah, you can't just turn it off and back on again. It needs some time quickly.
Okay, there it is.
Let's see if it actually works though. Okay. Yeah, and I find that so when you're reaching for the keyboard and you have that grip, then the ability to pause and do that release is really good. Like, but of course when you're playing, a lot of times you don't have that time.
Right.
So that's why I'm kind of fortunate to play an instrument where I play little bursts and I get rests because I do get time to like allow my hand to open up again, allow that feeling to to just release, extend the hand.
Give me 1 minute. I'm grabbing a cable for that.
Okay.
Do you have anything about your experience, Eric?
Well, what was happening is the finger that I needed the most is the one that was dystonic, and it would curl and I could reset, and it would curl again and reset, but it was really hard to be able to continually play because of the nature of the instrument. I need that finger all the time. So it just completely made it impossible to really play at all.
Did you notice it in other areas of your life? Or?
Yeah, same thing with computer, or anything that I used my fingers with. And it wasn't just the tabla drums, even when I played like a djembe or some African drum, the same motion would happen, and it would be really painful because I'd be hitting my finger against the drum, and I couldn't reset it fast enough. That was the problem.
I'm curious, what would you do to reset it?
Well, if it was here, I could quickly get it back into position, but it wouldn't hold. It would just get right back into the dystonic curl or whatever, and then it would take a second to get it back. It was just a constant process.
Well, let's hope for the best.
Yeah.
We'll see how long this lasts. So. This is Jan Fleischer. Do you want to turn the light off in the front?
Fleischer began to notice a problem. 4th and 5th fingers of his right hand were cramping and curling up. No one could tell him what was wrong or how to fix it.
So this is Menuhin. Now Menuhin is not widely known, but was a great violin prodigy, of course. But he had dystonia in the right hand, almost certainly. This is him from the mid-40s when he was out in California. Really amazing playing. But in the 60s, he developed a problem with his right hand that really never left him. And it was a problem controlling the bow in the lower half, particularly when he was playing off the string, which you can see. And this is in the early 80s. He's okay here, he's playing wonderfully. But when he plays off the string, he's definitely struggling. So this is not a new condition. This is something that's affected many, famous people. This is what we know about it, that this is a disorder that overwhelmingly affects men more than women. It affects the hand that's subjected to the greater technical burden. That certain instruments are more commonly affected in the piano, violin, guitar. The pattern of the dystonia often is related to the mechanical demands of playing, and that there are enough examples that are probably not more anecdotal that peripheral trauma can change, can trigger the development of dystonia, and that this is a common condition. It's about 1 in 200 professional musicians. So this is Eric at one of his earliest visits, and he's showing the problem in his right index finger with the curling, but it can affect the left hand of guitarists. And this is a guitarist who has it in the 4th and 5th fingers when he's playing. This is a drummer who has it in the wrist. So every time he picks up a stick to drum, his wrist will tighten. And he does not have the freedom in that. It can also affect, as we saw in Million's case, the right arm with the shoulder girdle, with the arm elevating. So again, in all these patients, the hand and the arm is completely normal in every other task. It's just in the task of playing their instrument. This is a rock drummer who has the problem in his left arm. So as he starts to play, his arm has a very complex involuntary movement. So it's a very complicated disorder. So the way our thinking of this condition has evolved is that somehow there's some sort of predisposition, what we would call an endophenotype on the left, either due to genetics or family history or gender, etc. And something happens triggering people into this dystonic prodrome, and then if it's not recognized and if they're unlucky, they end up falling into the dystonic network where they have the dystonia. And the idea is that some of these treatments maybe can bring them back into the prodrome or into the endophenotype, and that's not just sort of fantasy. This is a patient of a colleague in Germany, Eric Altenmuller. This pianist has pretty severe dystonia in the right hand, with flexion of the 3rd through the 5th fingers. Now, here he is. This is an hour later. So what did Eckhart do? So this patient had told him that he noticed that when he smoked marijuana, that it got better. So he actually did a controlled double-blind trial of THC, and sure enough, in that patient, for whatever reason, this was an approach that suggested there was a pharmacological treatment. This is a patient who had dystonia of the left index finger when he played. And he built himself a brace. But that's not a very effective strategy. But he was then injected with botulinum toxin and did beautifully. So here is 2 weeks later, he looks great. Now here he is 6 months later, the toxin is gone. But actually the dystonia was gone too. So he had a sustained response, which we don't understand. He called me up 5 years later, actually, and came in, and it was still more or less gone. So it doesn't really make sense. So what is this thing we call botulinum toxin? So I had the pleasure in May of meeting the genius guy in the middle here, Alan Scott, who's an ophthalmologist. He's still alive and he's practicing. He's 87. This is all his idea, the idea that you could use the most potent toxin known to man and use it in such microscopic doses that one could selectively slightly weaken muscles to treat overactive muscles, which he first applied to strabismus and then was applied to other forms of dystonia. So the challenge is that if you have patients who have the dystonia, how do you effectively treat them? Because each patient is different. Each patient's trigger is different. The pattern is different. The muscles that are triggered are different, and you have to make them better quickly in our treatment of other patients with cervical dystonia or blepharism. We have a little bit of time, but time is precious for physicians. They have different needs. So really what has been learned in the last 5 or 10 years is how important the anatomy, particularly of the hand, is. So these two techniques, one is electrical stimulation and the other is high-resolution ultrasound, the same ultrasound you use for fetal ultrasonography and cardiac ultrasonography, can be used on the hand by my colleagues to get very, very pinpoint resolution of where the toxin's going. So this is, I don't expect anybody to know this, but this is an ultrasound of the arm. There's the ulna, the bone, and each of those things up there is one of the fascicles controlling one of the fingers, 4, 5, 2, and 3. And this is a real-time ultrasound, and you can see them moving as the person is asked to move each individual fascicle. And then you're going to see the needle actually pierce the skin from above into the second fascicle, the muscle that controls the second digit. You can see it coming in, and then it's stimulating that muscle, and you see it twitching there. So you know you're in it, and then actually when you're putting the toxin in, you can even see the toxin going into the individual muscle fiber and not into the adjacent one, because of course you want it to go exactly where it needs to go and not into the adjacent muscle. So the trial that we set up more than 6 years ago was this. It hasn't been published yet. It will be published probably next year. And this had a couple of novel design features. So the first problem was if you just try to select all of the muscles looking at someone and the doses and etc., you can't get it right just on one look. So by using a booster approach, which is a novel approach of giving them an extra amount at 2 and 4 weeks that allowed the dose to be individualized. So it was a placebo-controlled study, so the patients either got active drug or they got placebo, saline, and then crossed over into the other line. So this is Eric at his initial visit. You can see the problem he has in that right hand. And then he went into his initial, he was injected. This was him 2 weeks later. So he's clearly better, but it's not perfect. Okay, and then he got a little bit more. This was him at 4 weeks. So he was nearly perfect. He got just a tiny bit thin. And that's when the injections of the active stopped. This is him at 8 weeks, where he felt that he was more or less as good as he could be. Again, we don't know if he got active or placebo, but if it's placebo, it's quite a placebo. And what we've learned actually from 21 patients that went into this is the placebo effect in this condition is very close to 0, which is not true in Parkinson's disease and other diseases, but you don't get a lot of placebo benefit for whatever reason. So then he went into the other arm. Here he's 12 weeks later, he's still very good. And he starts to get injected in what we think is saline. And it's starting to come back. I want that finger straight. Yeah, I want to get this. Yeah. And this goes on, and as it wears down, the effect starts to come back. Now what this allowed though was Dr. Simpson to then individualize the pattern that needed to be injected so that it can be done at regular 3-month intervals and all. And this is him playing with the New York film, actually. He shared that picture. And so, 2 flutists were involved in this. This was one of them. This is an individual who has flexion of the 4th and 5th fingers. So it's pretty clear that this is a problem. And this was the same person at the middle of the trial. There's still a little bit of flexion in the pinky. But it's, and these will all be rated blinded, and so there's no bias, etc. But the thing sort of speaks for itself. And this was Stephanie. So her problem was in the middle digit on the left hand, flexing down in that middle finger. So what David Simpson, my colleague, was able to do is just selectively go after that digit. And this is within the trial at the period of the best effect. So again, everybody is different, they have their own baseline. And then afterwards, she's continued. This is now an open label fashion. So, the point is that not everybody is going to have an effect as robust as that. Sometimes the patterns are much more challenging. There are many more muscles involved. The toxin is not a panacea. It can't make somebody who's an amateur into a professional. It can't make a professional into a virtuoso. It can only do as much as it can do. But there was a lot of nihilism and a lot of negative press about the effects of botulinum toxin in musicians, especially in the 1990s and 2000s. A lot of that was because patients would be injected once, sometimes without EMG guidance, certainly without ultrasound guidance. They get a tiny bit of benefit, but then they wouldn't come back. So people just said, well, this doesn't work. Well, like anything, the devil is in the details, in how it's applied. It's high value real estate. It's all about location, location, location. It's about the skill of the injector, who are my colleagues who do this for a living, and they get better and better and better at it, like anything, and about the selection process. So I at least from this perspective, there are a lot of alternative approaches that are extremely helpful, such as pedagogical techniques, retraining techniques, etc. We sometimes even use oral medications, and we use them together. This is not an isolation, it's not an exclusion. This probably works better as patients work with a master teacher and learn how to work around the dystonia and to accommodate to it and improve over time. But to sort of take the approach that's sometimes out there that this is something that shouldn't be done, etc., I think isn't giving at least some patients the opportunity that they have to improve.
I think one of the challenges for a person in a position like myself, and of course certainly Victor, is well, we kind of are the master teachers, so it's hard to know where to go and whether to go. I mean, it was hard to come out and say I have dystonia, but I think it's really important for people in high positions to do it because in a way we have a luxury of doing it. I have my job, I have tenure, and so it was something I wanted to do. And also being open about my condition allowed me to find Dr. Frucht. It allowed me to find Joaquin Farias up in Toronto, who I learned a lot of exercises from. And so that was, because for me, that kind of teacher that I need, there's not many people that do that sort of work for flute. Keith Underwood works in the level of the body, but there's just really few people that are really that smart about biomechanics and what proper movement looks like in a musician and a flute player. So it's kind of hard for people to know where to go. And I guess one of my reasons for doing this panel was to kind of, I'm hoping to bring like the medical community and you know, so like the natural approach together, so that there, because I do believe what, like you said, that the combined approaches work the best. So.
Can you speak about specific other approaches that you did in tandem?
Well, prior to entering the study, I did go up to Toronto and I went to a seminar of Joaquin, and it was really helpful because it helped me to understand the condition, not why it happened, but like, well, how is my body supposed to be moving? First thing that became apparent to me is that I needed to calm down my nervous system. So I had to work a lot on that. And then regarding exercises for like what I do, I have to, first of all, I had like this death grip on the instrument. And it's just from trying to control, because I feel like, I feel like I'm losing control when I play. Like you try to play a scale and it's like, you know, so I'm gonna grip onto that thing, and you know, and so then you develop this habit of gripping. That's not the dystonia. The grip is not the dystonia. And then there's this whole level of compensation, which maybe Dr. Frucht can speak about too, but like, to be able to diagnose is incredibly difficult because there's so many layers of compensation, and if you don't get a really good diagnostician, they will look at that compensation and maybe inject you in the wrong place, and so then you're adding insult to injury. So do you want to talk about that?
Well, we spend a lot of time looking at people, and they all bring their instrument. I think you're right. I think it's an iterative learning process, and it helps to have more than one opinion, because having people see both myself and David, we'll usually talk afterwards. It's sometimes not that straightforward when you look at somebody to know which is the triggering muscles, which are the dystonic muscles, and which are the compensatory muscles. But you're absolutely right. If you inject the compensatory muscles, you will learn that you did the wrong thing pretty quickly.
What about you, Eric? Did you seek any other therapies at the same time?
I went to, I guess the term is called Rolfing. It's a deep muscle stimulation kind of person that my tabla teacher suggested I try. He was stumped. I work with my tabla teacher very closely, and we were kind of stumped with the whole situation. So when I started receiving the Botox, what was great is that it was gradual, and I had control of my finger again. And when I started to practice, I started really slowly at the beginning again, and sort of worked everything really slowly. Didn't try to play very complicated things, and just working through the process, it just felt like I had my hand back, and everything was back to normal again.
Question?
Well, I was just wondering if you could talk about the pathophysiology of this. You're a neurologist, and yet everything I hear is muscle. So where is the bad stuff happening in that?
The bad stuff is happening within the brain. The question is where in the brain, and it's not one location. It used to be thought that there must be a target either in one of the deep nuclei in the putamen and the striatum of the brain. It's a motor network disorder, so it involves incredibly complicated relationship between the motor cortex and the surface of the brain, the deep nuclei, the cerebellum, etc. The best analogy I can give you is that if you have let's say the latest Mac desktop, okay? And everything works fine on it, except every time you boot up Microsoft Excel, it doesn't work quite the way it should be. But everything else on the computer works just fine. Now, the question is, why don't we fix it within upstairs? Well, that is a treatment that works for generalized dystonia. For genetic dystonias, we do DBS, deep brain stimulation. We sometimes use oral medications, etc. For musicians' dystonia, we don't have a real way to do that. While it may look simplistic that you're just injecting botulinum toxin, actually, it's not so obvious what it's doing. The amount of weakness that it's causing is quite mild, yet the benefit is quite striking. The question is why? And almost certainly it's having a central effect. Not from the toxin moving anywhere, but from changing the control of the limb and the way the limb is controlled. But that is somewhat speculative, we don't know that. But it's not, you're right, it's not in the hand, and it's not in the muscle. The hand is fine.
It's almost like the injection's retraining your brain.
A little bit.
Yeah, because when I'm sure, I don't know about your path, Victor, you can speak to that, but I think Eric, you and I both probably went through the same pathway before we did Botox. I mean, I had some really fun nerve testing done. Never want to do that again. And my nerves are normal. And then I went to the hand doctor, my hand's normal. I went to the spine surgeon. He offered to operate on my spine. I said no thanks. He said it might help me. I don't know, I went everywhere. I had acupuncture, which is really good for calming down the system, so I do recommend that. PT, OT, what else did I do? The Tai Chi, Alexander, I did it all. and the best combination, the best thing is for me was the finding Dr. Frucht and also working with Farias as well. So in conjunction.
I, as a result of listening to you, I went to Dr. Frucht, and I did have one Botox injection, and what happened to me, and it's in my left hand, it affects my writing as well, because it's my dominant hand. I'm not a professional musician, I'm an amateur. What happened to me is, like, about a week after I had the injection, for one day, I felt like my hand was absolutely normal. And then it disappeared. I don't know if that's odd. The other question I want to know is, how often should I be coming back? Because I'm not coming back. I mean, nobody said to come back after a certain length of time or whatever.
So we usually will see people back, certainly after their first cycle, within 2 or 3 weeks. And then often they'll get, if we can arrange it with insurance, in practice, a booster injection to try to optimize. It usually takes, though, for any patient with cervical bleph, writer's cramp, etc., it can take 2 or 3 cycles to optimize. This isn't sort of there's no algorithm to predict with all of the independent variables, person to person, size, gender, age, all these things. It's very much experiential.
So I should come back.
Well, I mean, the fact that there was any improvement, and the fact that there was even a marked improvement for a day or so, probably means that it could be optimized.
It could be what?
It could be optimized.
Optimized, yeah.
And even but that said, like, it's not like I don't have bad days. Like, yesterday my hand did not feel good. So far today, feels okay. It does kind of do this, and the stress levels contribute. Sleep, super important. Taking care of your body.
Yeah, absolutely. I have not tried everything. I've tried very little because I just found out what it was very recently, and I got officially diagnosed with dystonia even more recent, and I wanted to get diagnosed so that insurance could kick in. But my wife just got a hunch one day and went online and found a woman in Spain. and her name is Ruth, spelled like child, Chiles, but probably pronounced Chiles, from Granada, Spain. And her website intrigued me because from what I had read, and I'm not an endorser or anything, so I'm not, and I can only speak to it as my thoughts about it. I'm not speaking for her, but it interests me, like Botox, when I first heard of it, because it just seemed out of the box. This was different, you know. And I will say this: at first, I was like definitely afraid of getting a shot in my hand, you know, until I read your article. Because you said that you got back to 100%. I can't even imagine what 100% facilitation feels like. But to get there, man, I was like, who is this doctor? I gotta just, you know, and then maybe the brain would remember like it seems it has for you. But this woman on her line, I'll try to be fast about it. She was talking about the cause of the dystonia, not just the treatment. And some of her treatments, and again, I'm talking what I really don't know about, just what I read. But her treatment, she said, she was using some of the treatments. One of the treatments was something called brain spotting, which is a treatment that they use to help treat and cure trauma patients. But my understanding of this woman's understanding of dystonia is that there is some kind of trauma or stress that is way deep in the subconscious. We probably don't even know what it is, but it's deep. And apparently there was a doctor who was pioneering this thing called brain spotting, which has to do with where the eyes look. I was talking with this woman at one point. I decided to have a treatment with it, just to pay for it. And she was asking me about some things that had happened in my life. First she was asking me, when did I feel like this was coming on? Basically, what was going on in my life when I felt dystonia coming on. And so I could go back to when I could remember talking to my bandmates about it. And I thought about what's going on at that time. And it was a time in my life where my wife and I were going through some struggles. Also, my kids, I have 2 kids that are at the age where they can talk now, and it's every time I come home from tour, it's like, Dad, how long are you home this time? When do you gotta leave again? And and as small as that is, everyone's a little dagger in my heart, like, wow, they're really feeling me leaving or going, they're already thinking about it, And in my mind, like sweeping a little bit of things under the rug, after a while there's a big mound over there. And what I think this woman is saying is those little things build up, whether they're conscious or not. They're in the brain. And where you can mentally deal with it or not, and you seem fine, your body is saying, no, you're not fine. And where she says, like a little baby's, or anyone's reaction to stress or trauma is to contract. A newborn baby cries and the hands do this. And she's saying that's the body's reaction to this. And until you go through it and deal with it, it can keep coming back. Because I heard her say one time that the brain doesn't know time. So it thinks these things are still going on. And until you go through it and say, this is no longer needed or whatever, however you get there, at that point, the dystonia or the symptoms can't keep coming. So, I don't know. I hope there's something to it. And I think, what I'm hearing here is what they're saying, and I totally agree with, is that the different treatments together, maybe everybody has a little piece of it. But I am interested in what is causing it. Not only what are the treatment of the symptoms, but what is causing it. And the reason I have been vocal about it to my friends and online and interviews is not so much for me, but I I want to get to the bottom of it for everybody. I hope nobody else has to go through this. And for me to keep it secret, for me, it's about me now. I don't want anybody to know that I have it. I want everyone to know I got it. Because every time I talk about it, somebody gives me a piece of an answer. Like the cartoonist who drew Dilbert, he wrote about it in his book. Yo, let me go get that book. I got the book and found out how he cured his. You know, and so I'm learning a lot lately. But another thing that interests me in this woman is when I was talking to her, she was asking me about these things that happened in my life. And my eyes went to a specific place as I'm talking to her. And she says, notice your eyes went to a place. Keep them there. Don't move them. And it was pretty interesting when I kept my eyes in a specific spot, and she said, think about what that time felt like. Your kids are talking to you, you're going through this with your wife, blah, blah, blah. And I just felt my eyes start to well up. And she's saying, on a scale from 1 to 10, 10 being the most, what does this feel like to you? I'm saying it's about a 4. She said, okay, let's get it to go higher. Feel it real, and to not, I don't want to, like, especially on camera where I know everyone's going to criticize. Well, not everyone, but a lot of people, and that's not what I want. I don't want to go through what her thing is, but it was really, really interesting because she had me deal with that issue of my life and look at it. And then we went somewhere else when we started talking about something else, and another 20 minutes went by, 30 minutes went by, and she said, okay, let's go back to the other thing. Put your eyes back where they were. Let's try to remember what were you thinking about when your eyes were there? I couldn't remember. It took me a minute or a minute and a half to even think about what was I thinking at that point? What was it? And after a while I said, oh yeah, my kids. Daddy, when do you leave? And I said, I apologize, I couldn't even think of it. She said, that's normal. She said, because your brain doesn't need to remember anything. I played a show last night, and a friend of mine was there, and he said, your right hand, which I have it in both. He said, your right hand looked better than I've ever seen it. And I told him, I said, I know, and I'm trying not to think about it. Because every time I have a good day, I think about it, and the next show is horrible, But maybe there's something to it, And so my thought is, wow, maybe I could get, some injections and feel what 100% is, go up to Toronto and, learn about posture and deal with a possible cause and actually cure this thing. I'm an optimistic person. I know that there's an answer. We just maybe do or don't know what it is. But there is one, and we're going to find it.
I'm wondering, after receiving the injections, if you have to adjust the amount of time playing, the amount of time practicing, that could possibly override the benefit that you've received from the Botox.
That's an excellent question. I practice in a completely different way now. Leading up to getting dystonia, I had a period of great stress. I had a premature baby, very, very premature, 1 pound, 11 ounces. Got a divorce and, had just all sorts, and then, when you have a baby that small, he needs a lot of therapies. And so before that, I was a very, very organized, detailed practicer. I'd get the score, and I would, I'd organize my practice sessions into crazy chunks like that would make no sense to anybody else. But then I had to start cramming, and I just was like, I would just I play so much at the opera that I would just that is my warm up. I'm still warmed up from last night. So then. Once I got dystonia though, and I found out I couldn't play. I just playing was horrible. I couldn't practice. It didn't feel good at all. I would cramp up and I couldn't do anything, so it was depressing. So when I found Dr. Farias, I just do exercises on the flute that don't have anything to do with playing. I mean, it's just basic movement, and it's basic movement from here, you know, like, because my fingers were not moving from this joint. So that's that, and then I've come up with other things for myself, like I put my flute upside down on my lap and I allow my fingers to fall open instead of lifting, so I can feel what that feels like, because that's how the fingers should feel. The gravity helps to get the proper feeling, and then I flip the hand over. Just all sorts of stuff, and just talking with people and like finding out what they do. It's like I just try anything. Yeah. Yeah.
You mentioned once about doing movements in portions,
Oh yeah.
and I thought that was interesting. You know.
Yeah. Part of the exercise is doing like. So it's like quick up, because what we're trying to do. So the problem with dystonia, you'll correct me if I'm wrong on anything, but there's an imbalance between the flexors and the extensors, and so the flexors are overly active compared to the opposition. So all muscles have to work in pairs. So the problem is my flexor is overactive compared to my extensor. So the exercises have to do with strengthening the hypotonic, which is the weak muscles. So I'm trying to avoid the flexors and strengthen these. So doing the lifting quickly and then slow down or in segments down is kind of like doing like, you know, like you're trying to like stimulate this muscle rather than the bottom. Did I say that okay?
Yes, I have a question. When you're enraged or frightened and you get shaky hands, is that similar neurologically? And it's just transient, or is that?
No, that's not dystonia. No, it's
No,
probably
it's-
just what we call enhanced physiologic tremor.
You have somewhat of a skewed population on the stage here, meaning these are people who've been diagnosed. If someone presents with these symptoms, how likely is it they're going to get a diagnosis of this as opposed to, say, a functional neurologic disorder or conversion disorder in these days?
So the question for those who may not have heard is, how likely is it that a musician who would come in with a playing-related problem would be diagnosed correctly with dystonia versus a functional movement disorder? So the track record of medicine and neurology in this is not that good. For most of the 1940s, 50s, 60s, even into the 70s, I would say most neurologists viewed all patients with dystonia, even pediatric patients, torticollis patients, as functional. So patients with cervical dystonia who would have a neck that looked like this were told they were looking away from a stimulus that they didn't want to face. I mean, it sounds crazy, but that's what they were told.
But nowadays, say someone walks in,
Right,
that's
so
fine.
one of the things that has changed things is the internet. It's been a decade or more since I have had a patient come in who I'm the first person to say the word dystonia to them. They've usually already been online. They've had exactly your experience. They've been to a chat room or they've seen a blog. There's a post page on the Dystonia Medical Research Foundation of Musicians Dystonia. They look at that and they say that looks like me, and then they talk to someone. So I think also there's much more awareness now of the condition. It's less likely. I can tell you that in the United States, I have yet to see a musician who would come in and who is saying that they have a playing related impairment and that they actually have a functional movement disorder. the musicians are so at risk, so underinsured, so underprotected by disability and other support networks that there's absolutely no secondary gain. Some colleagues in Europe have seen it. You know, I've been doing this now for 23 years. I haven't seen it yet. So I think it's, you know, somebody who's inexperienced might make that mistake. They might make the mistake even for a patient with torticollis or blepharospasm. spasm. You know, we see that. You know, you can't, unfortunately, you can't diagnose what you aren't familiar with and have never seen. If you don't know what you don't know, then that's a problem.
I just want to comment that prior to becoming your patient, I saw many doctors, and my hand doctor didn't know who to send me to. Like he said, he's a good hand doctor. He said, if I could inject you with, like, you know, something, I would, but I don't see anything I could do with, like, cortisone. If I could operate on you, I would, but there's nothing wrong with your hand, and I don't know who to send you to. And the only reason I ended up with you is because I shared with our harpist that I was going through this, and she said, well, you have to see my neurologist. And that was Patrick Stugin. And he took one look at me and said, I know who you have to see. So, but it was very difficult to find a path, even through the medical community, to you. So it was interesting. Unfortunate.
Yes, another question. My second career is nursing, actually. So the medical thing was very interesting. So when you were talking about oral medications, were you talking about steroids? Were you talking about things like pain medication, like gabapentin? Were you talking
No,
about
the oral medicines are the ones
muscle
we use for the treatment of dystonia, and they're they fall into four major categories. One are anticholinergics, so drugs like trihexyphenidyl, baclofen, clonazepam, and occasionally either levodopa or dopamine receptor blockers. But anticholinergics are the ones that have been studied best for musicians. And at least in the German experience, there's some very profound benefits in some patients. But these are much more commonly used for patients who have generalized dystonia, genetic forms of dystonia, etc.
Not this population.
Not this population.
Yeah, thank you.
Yes.
Do you know, is there any study yet on the use of, specific use of acupuncture to replicate the same effect as the injection of the, of the botulism? Yes.
I'm not aware of a study of that. There's an interesting point, though, because what is clear is, and has been known for a very long time, if you take a patient who has a hand dystonia and you inject them with a local injection of lidocaine so that you anesthetize the hand but don't weaken it, there can be a profound and temporary improvement in the dystonia, which can be quite remarkable, lasting several hours, and then it wears off. And in other countries, like in Japan and all, they actually use that as a way to guide the treatment.
But the effect of the botulism is thought to be better because it's more longer lasting?
It's very long lasting.
Any final questions before the performance?
Well, I was wondering how OSHA and workers' compensation deals with this matter. It would seem to me that it would be a very steep uphill climb to get that on board for OSHA.
So, so fortunately, when patients have good insurance and good disability insurance, which is not common, but when they do, we've been very successful in stating that this is a workplace-related difficulty and a source of disability, and we are quite successful in fighting for their disability benefits.
Last question, yes.
You'd mentioned that the treatment of this is more difficult if it's in your dominant hand.
I believe that's the case because, you know, because you don't have that dominant hand to refer to when you're trying to decide what proper movement is. Because when you have dystonia, you kind of forget. Like, for example, I said like, my grip became like a death grip. It's power grip. That felt normal to me. So it's the whole normalizing of things that are not normal. And so then you don't even know what normal is. And when I got my first injection, I had the placebo first, and didn't work. And then when I had my first injection, I had a response, and then it continued to improve throughout the subsequent boosters. And I've had even more effect outside the study. And I'm kind of going like this, like I'm not returning to baseline. So I got off I got a tangent, but like because it's my dominant hand is something I refer to, that hand is functioning normally. So then I can like have that, you know, reference point.
All right. Thank you, everybody, for your questions. Do you want to speak a little bit about what you'll be performing next?
Oh, yes. So because Eric specializes in Indian music, we thought we'd perform this piece that's called Morning Love, and it's a piece by Ravi Shankar and Jean-Pierre Rampal that was transcribed from their performance. And we have rehearsed this sitarist who's in the back there, Abhik. He just flew in from India, so we rehearsed for 30 minutes yesterday. And Victor, since he was a surprise guest, has never played with us, so so this will be a little jam. So. Meets West here. One music stand for 4 musicians. This is my first time playing with a sitar and an electric bass and a tabla, actually. So this is like this is magic. Okay. I've been assured we're not getting kicked out of here, so. And I know we're running late. I appreciate this. Thank you, everybody. And, well, you know, I'll be around for a couple more minutes if you have any more questions. And I have to play 5:30 numbers.